Good afternoon, and welcome to today's Lunch and Learn webinar for the Iowa Pediatric Mental Health Collaborative, Understanding Augmentative and Alternative Communication, Medical Provider Roles and Considerations, presented by Jenny Brodell and Krista Davidson. My name is Kathy Dixon, and I'll be moderating the session today. I will cover a few housekeeping items before we begin. The presentation Following the presentation, we will have time for questions, so please use the Q&A feature in the webinar toolbar to submit your questions. The webinar will be recorded, and the link will be shared in the follow-up email after the session. Instructions for how to claim continuing education credit will be uploaded to the chat section and sent in the follow-up email after the webinar. So without further delay, it's my pleasure to introduce our presenters. Jenny Brodell is a clinical associate professor and speech-language pathologist at the University of Iowa in the Department of Communication Sciences and Disorders. She specializes in evaluation and treatment in the areas of autism and pediatric speech and language disorders. Jenny supervises graduate student clinicians and provides direct services in interdisciplinary autism diagnostic clinics, social skills groups, and parent education programming to support communication development. Jenny is the past president for the Autism Society of Iowa and the American Speech Language Hearing Association state advocate for reimbursement for the state of Iowa. Krista Davidson is a clinical professor and speech-language pathologist in the Department of Communication Sciences and Disorders at the University of Iowa. Her academic and clinical focus includes the preparation and supervision of graduate student clinicians who serve individuals with augmentative and alternative communications AAC needs across the lifespan. She's also the inventor of Rescue Voice, a mobile AAC application designed to support communication with first responders and medical professionals. Welcome, Christy and Jenny, I'll turn it over to you.
Thank you. Hi, everyone. Thanks for joining us today. So like Coffee said, we are going to be presenting on understanding augmentative and alternative communication, and we'll be talking through medical provider roles and considerations. So my name is Jenny. I'm going to be talking first. As we just said, I'm a speech language pathologist and clinical associate professor, and my colleague Krista Davidson is on here. She is a clinical professor as well. We're both from the Department of Communication Sciences and Disorders. So today we have three key pieces of information we want to highlight. The first is that we want participants to be able to differentiate between speech and language, and more specifically between expressive and receptive language, so that we make sure we have a shared understanding of the skills that AAC might support. We also have goals for participants to be able to identify 2 reasons that you might refer an individual for AAC supports, and then state 3 professional responsibilities within your role as a medical provider in supporting patients in acquiring AAC supports. So we'll start by discussing an overview of communication skills and modalities. Then we'll move into learning about assistive technology and augmentative and alternative communication. And at the end of the talk, we'll save about 10 to 15 minutes for questions. We first wanted to review underlying skills and basic referral processes that would lead to accessing AAC supports. In general, we think about AAC as aiding in communication. So as medical providers, we want to, again, provide you with that shared knowledge of skills in this communication domain. And the 2 main skills we think about are language skills and speech skills. So language refers to the words, gestures, signs, and symbols that we use and understand to share messages and ideas. We know that language can be transmitted in many different modalities. There's verbal or spoken communication and language. There is gestural communication and symbolic communication, like which occurs with AAC that we're going to be talking more about today. There's also written communication. So we want to kind of broaden our thought about what language is, and it's not just talking. We also want to talk about speech today. Speech refers to how spoken sounds and words are produced. It's that precise execution of vocalizing and producing a spoken word or sound. Can go to the next slide. Thanks, Krista. Um, it's really important to think about those distinctions in communication domains to recognize that communication concerns can happen across any or multiple modalities and domains. Breaking down language a little bit more, we can see language concerns that exist within receptive language domains. So that would be things like understanding language, understanding words and general messages, understanding what words mean, how words relate to each other, difficulty doing things like following directions and answering questions. And then we can think about language expressively. So, how a person is sharing a message or an idea with another person. That might encompass skills like using vocabulary, putting together sentences, using grammatical markers, telling stories, and many other skills. So, again, difficulties can happen in either or both domains of language. Then, breaking speech down a little bit more, speech concerns can happen across multiple domains as well. You may encounter an individual who has difficulty with articulation or that precise production of a speech sound. So, for an example, maybe producing an S sound as a TH sound, like fit for sit. We can see difficulties in the area of fluency under the domain of speech. So, maybe a prolongation or a repetition of an initial sound in a word or phrase. So, I like volleyball. We could also see difficulties or challenges with the voice under speech domain. And that would be a difficulty or challenge at the level of the larynx or vocal folds, which are required to produce vibrations and aerodynamic movements that allow us to voice and turn our voice on. So, for an example, if someone had a paralyzed vocal fold, they might not be able to phonate or produce vibrations necessary to produce a vocalization. All of these areas we want to be really mindful of as indicators that speech therapy, and then more specifically, potentially AAC, which Krista will talk about a little later on, could be indicated for an individual. So, breaking these skills down even further, we know that all medical providers, especially as they're seeing younger individuals, are very mindful of milestones and tracking as individuals may meet milestones. Coming from a lens of speech language pathology, we think about breaking down acquisition of skills into those very specific domains I just introduced. We tend to recommend following ASHA's or the American Speech Language and Hearing Association's milestones in favor rather than the CDC milestones, just because ASHA's are going to be much more precise and again, more all-encompassing of those specific skills and domains that we talked about previously. As medical providers, you all are probably the first line of defense in noticing potential concerns in any of these areas. And in many cases, being seen by a speech language pathologist does actually require an official referral or prescription from you as a medical provider. So that insurance would cover an initial evaluation, or so that, a parent can become aware that they have the option of contacting the AEA or a school-based service. So I just wanted to take some time to review some basic milestones across those domains and skill areas that I referred to above. You can see in receptive language from birth to the second year of life, there are lots of sub skills, and this is not even an exhaustive list that we think about past kind of alerting to sounds and voices and understanding simple words. We want a child to be able to show a response to sounds, noises, voices, more specific than just to sounds. We want a child to be able to respond to their name, to inhibitory words like no, to simple phrases like get shoes. A young child, even before the age of 2, should be able to understand simple where and what questions. Where is dada? What do you want? Um, they should be able to follow simple 1 and 2 step directions. They should understand words for actions, items, and people in their familiar environment. And they should understand at least 50 words, if not more. In that expressive language domain, kids should be able to start off with cooing, vocalizing, and then babbling, which includes those consonant sounds. By age 1, they should be using 1 to 2 words, and then by age 2, they should be combining 2 words to use simple short phrases. We should be seeing gesture use, so things like waving, clapping, um, shh, all types of gestures by age 2. And they should have a vocabulary of at least 50 different words by age 2, including words for common items, but also for actions. So, not just nouns. They should also, by age 2, be starting to use simple grammatical markers like possessives. It's the dog's food, and personal pronouns like my or I. In that social domain, we want kids to be smiling, laughing, responding to facial expressions, imitating and initiating interactions, pointing and gesturing for communicative intent, and then by age 2, increasing their communicative intentions. So, are they using the words or other communicative strategies they have for social purposes, like requesting, commenting, protesting, asking for help, gaining attention, all of those different reasons. And then thinking about speech, is the child able to produce vowel sounds, consonant sounds? Are they able to vary their intonation in an adult-like manner? We don't expect by age 2 that kids would have very clear speech, but we would expect that they are at least attempting to produce a variety of vowels and syllables. Go to the next slide. Thanks, Krista. This is going to be my last general milestone slide, but again, I just want to kind of go through this up to age 5 because making an early referral is so important in one, acquiring speech therapy, but then two, starting to think about AAC, which we'll talk about in just a minute, to ensure that a child we're catching a child during that very critical period of development and helping build their skills when they're in that prime and have that neuroplasticity to make a lot of gains. So for kids between the ages of 2 and 5 years, we expect to see really exponential growth across these skill areas. Receptively, a child should be able to answer all types of WH questions up to the point at which they're 5 years old. Starting at 2, they should understand function of objects. Then 3 to 4, they should start understanding more location words. They should be able to start recognizing signs and logos. So they're starting to recognize written language as well, even if they're not reading necessarily. They should be able to understand time concepts and very specific location words like far and near. They should be able to understand more complex directions like rules to games by the age of 5. Expressively, in the year 2 to 3, kids should be using about 2 to 4 word combinations and phrases, and they should be picking up more of those grammatical markers like plurals, verb tenses. They should be able to start formulating simple questions. 3 to 4, they should be able to start telling a simple story like, I fell down and hurt my knee. They should be able to use articles, so the and comparatives like big, bigger, location words. And really by age 5, they should be using pretty grammatically intact sentences, so including those small word endings to mark tense of verbs, number, gender, all of those things. They should be starting to use time concepts and then be able to tell more precise stories that have a sequence. Socially, kids continue to increase their communicative functions and do things that have higher cognitive complexity, like sharing their opinion, negotiating, pretending to read with other people. And by 5 years old, they're starting to engage in cooperative play with others and have back and forth conversation. And then speech really again explodes throughout these years from 2 to 5. You can see on this slide the different expectations for developing a variety of consonants by age. Again, by age 5, a child should be producing most consonants accurately, with the exception of maybe R and TH sounds. And and to unfamiliar communication partners, a 5-year-old should be mostly intelligible, meaning they should be well understood by communication partners. All of this to say, when you as medical providers are are having those appointments with individuals, it starts with your referral to a speech language pathologist to access that AAC and that speech therapy in general, because we as speech language pathologists um, have the most specific training and expertise in considering augmentative and alternative communication options. So lots of times we get a question about when should I refer a child, and there really um, is no time that's too early to refer a child. The worst thing that can happen is that we might say like, oh, they don't need speech therapy right now. Speech therapy is not indicated at this time. Um, but there's no such thing as a referral that happens too soon. So you can refer a child on for speech therapy services, and more specifically, consideration of AAC at any age if there is a concern that milestones are not being met or if a caregiver has a concern. All entities, meaning medical facilities, outpatient facilities, private practice, school-based facilities like the AEA, will do an initial evaluation to determine if services are medically necessary or if that child meets eligibility criteria for services. Just kind of thinking practically, almost all insurance companies will cover an initial evaluation as long as there is that doctor's referral. That's the only criteria for almost every insurance company. And by law, schools have to investigate um, if a parent requests an evaluation. So again, um, just kind of making that referral is really sometimes the only barrier from a family accessing those services. Typically, speech and language services geared towards communication can start around 12 months of age. If you're referring someone for feeding services from a speech language pathologist, which we are not going to talk too much about today, those can start as early as a few weeks old. But talking specifically about communication, usually we could start to be able to justify services around that 12-month mark, sometimes earlier if there's another kind of significant factor to consider. Another reason to refer a child, even if there hasn't been an explicit concern about communication brought up, is if you know the child or individual you're working with has one of these common comorbidities that goes hand in hand with a communication need. Some examples are intellectual disability. So we know that if a person has impaired cognitive abilities, language is part of cognition. So we can almost always assume that there would be a need to support communication skills. Very similar thing with autism. Autism, by definition, is half of the criteria is a social communication need or difference. So again, the likelihood that a person would benefit from speech and language services is very high. Other common comorbidities might be cleft palate. In these cases, structurally, that might lead to a difficulty with articulating sounds, so speech skills, which a speech language pathologist might support. Other very common comorbidities, traumatic brain injury, likely necessitates support with executive function skills, which is under the purview of a speech language pathologist, and other cognitive communication skills, hearing loss, because we know that individuals with hearing loss have more difficulty acquiring precise language skills like articulation, grammatical markers, sometimes social skills, and then any genetic syndromes that might include some of the common comorbidities stated above. So with that kind of information about how to take the first step out of the way, I'm going to have Krista transition into talking more specifically about, once we have speech therapy services set up, or once there has been that initial kind of recognition that there is a general communication need, how do we start thinking about AAC and what is AAC?
Yeah, thanks, Jenny. So AAC, just to break down on this slide, kind of the basics of what you need to know. First of all, that the SLP is the communication expert, but AAC is a team effort. So we coordinate and communicate and collaborate with the family, but also other professionals like occupational and physical therapy. And as Jenny stated, you should refer to an SLP for further evaluation. Any SLP can do this evaluation for AAC, but there are some SLPs who specialize in AAC or just have more experience with AAC diagnostics. So children as young as 18 months can successfully use high-tech AAC, and they can start much younger with what we call unaided AAC, so like sign language or gestures. And again, I want to emphasize the importance of early referral. Just like Jenny said, there is no harm in referring. It can be extremely beneficial to start intervention sooner rather than later. So evaluations for AAC are very comprehensive. We look at all communication modalities. We trial several different systems. We look at vision, hearing, motor skills, cognition, and language. And we do a combination of formal testing as well as informal assessments. We trial different devices. We do family interviews and observations. So what exactly does AAC mean? Well, as we've sort of been talking through the whole presentation, augmentative means to supplement or to add to someone's speech, and alternative means used in place of speech. So an AA system really means all the communication tools that a person uses. And really, we all use AAC every day because we wave, we text, we roll our eyes. So it's facial expressions, it's gestures, it could be sign language, body language, writing on pen and paper, and also low-tech systems and high-tech devices, which I will talk about more in just a minute. So I wanted to just differentiate between assistive technology and AAC because sometimes these terms are used interchangeably. But actually, assistive tech is a much broader domain. It includes any device, software, or system that helps an individual with disabilities or functional limitations perform tasks, improve their independence, and participate fully in daily life. So this includes hearing aids, but also wheelchairs, screen readers, even pencil grips. But AAC are just all the ways that someone communicates besides talking. And it includes, like I said, gestures, manual signs, books, and devices. So AAC includes some modalities that don't involve technology. So that's why I created this little Venn diagram to sort of illustrate that, that there are some unaided AAC modalities that just use the body, that don't have that additional component that's outside the body. But everything that is additional is that aided AAC, and then there's a whole broad area of assistive technology that can include things for mobility and vision and other sensory needs. So now I'm just going to talk a little bit more about those different types of AAC. So like I said before, there's the no tech option. It doesn't require a device or anything separate from the body. It includes gestures, facial expressions, and manual signs. A couple of examples there. But then we have low tech or non-electronic AAC. So writing with a pen and paper, picture symbols, or communication boards and books. These don't require any sort of charging or batteries, but they are external to the body, so they are something additional, but what we typically call low-tech AAC. And then we have high-tech AAC, which is what a lot of people think of when they hear that term. There's another term that we use called an SGD, and that stands for a speech generating device. So simply a device that generates speech output. It's usually seen as a tablet or computer, but sometimes they're dedicated devices, which means they're just for communication purposes. And then they can also be non-dedicated. So this would be like an iPad with a communication app on it. So I know there's just one picture here, but there are many, many different types of SGDs and communication apps on iPads. So companies on these high-tech systems, companies use a lot of different layouts, and they provide a variety of vocabulary page sets. And during an evaluation, we're going to determine the symbols, the system, the organization that works best for a child. And we're what we call feature matching to meet their needs. So there's also a lot of different access methods for AAC. And so I want to highlight that children with motor impairments, vision impairments, hearing challenges, they can all still use AAC because there are many different ways to access a system. So you can use your fingers or even a stylus to press the symbols. You can use what's called scanning, where you might use a switch that will highlight buttons across the screen, and you can select the message that you wish to express. Or even a partner might be pointing to these pictures, and the child can indicate their choice through a head nod or an eye blink. There's eye gaze, where you're selecting a symbol by gazing at it, either with a low-tech way of just looking at a choice, or through high-tech methods where they're looking at your eye movement and determining your selection that way. There's also head pointing, where you can use your head as a mouse to make selections. And there's settings on devices to adjust for a lot of needs. So children with vision and hearing challenges, you could have high contrast symbols, you could have enlarged text, you can have feedback when a button is activated, buttons can be highlighted when they're activated. There's a lot of things that we can adjust to account for these different access methods and different fine and gross motor challenges, as well as sensory challenges.
Krista, I was just going to jump in at this point and say, like, this is again, these are things like the speech language pathologist would be assessing for, but as a medical provider, we know a lot of people, a lot of your patients trust you, and they may come to you with, a concern or a question. And so just being aware that if a family comes and says like, well, we got a device or a program, but there's an issue with it or this feature is inaccessible, just kind of having that knowledge of like, well, do you think that whoever helped you get this device looked at these features or looked at these other accessibility methods, and just kind of knowing that that should be a part of an evaluation, and that too might be a reason to, think about referring or, empowering patients to ask those types of questions if they disclose a concern to you as well. I know this is something I hear quite often because I do a lot of autism evaluations for individuals who are, maybe they've already gotten an AAC device, and just being able to educate on like, oh, you could ask about these different access methods to the clinician you're currently seeing.
Yeah, thanks, Jenny. That's a great point. And just to emphasize that again, like I think a concern sometimes is my child is too fill in the blank to use AAC. And, breathing is really the only prerequisite for accessing AAC. So if they are blind, if they are deaf, if they have severe motor challenges, it doesn't preclude them from using some kind of system. We will figure out a way for them to communicate. So I think, again, if a family is coming into your office and they're concerned, they're thinking, well, my child can't possibly, access something like that. There are a lot of different ways that we can accommodate them. So on this slide, it is just an illustration of a small sampling of what's available. I know that it looks like high tech is at the top and low tech is at the bottom, but high tech is not better than low tech. It is just a continuum, and we look at whatever works best for the person that we're evaluating. But you can just see that there are single message communicators, there are iPads with apps, there are communication books and binders. There's just a wide variety of equipment that's available when we're thinking about AAC. And again, we're going to use that feature matching to figure out what works best. So Jenny mentioned this too a few slides ago about all the different conditions that might kind of trigger that, oh, maybe they're going to need a speech and language referral or possibly use AAC. So a variety of congenital or developmental disabilities like cerebral palsy, Down syndrome, or autism, acquired disabilities, someone who's had a stroke or has aphasia, or in children maybe a traumatic brain injury. Progressive conditions, again, this is more for adult populations, but like ALS, although there are some pediatric conditions that are also degenerative. And then also temporary needs. So AAC doesn't have to be a permanent solution. It may be something that is used temporarily when someone's intubated, or another example might be selective mutism. So they use it from time to time. This is just a few examples. Again, it's not an exhaustive list. It is not limited to these conditions. I've worked with children with many of these disabilities, but also who have apraxia or spina bifida or other genetic syndromes, cognitive impairments, and many others. So when we're looking at a high-tech system like a speech-generating device, there is a funding process. They are relatively expensive if you're getting a dedicated device for communication. And so we typically go through insurance to get these items funded. And the SLP is the person who's going to complete that evaluation and most of the paperwork, or what we call a funding packet. However, a physician prescription is required for most funding sources like private insurance and Medicaid. So you may receive a request for this script directly from an SLP or from the device company's funding department. And a newer requirement is that a physician visit is needed within 6 months prior to submitting a funding request, and that visit needs to include notation on the communication impairment. So it would be good practice to note a child's communication impairment at each visit so that documentation is there.
I was just going to jump in and say, Krista, that this is more if a person is like seeking funding through insurance. There's also not lots, there's also a couple of other ways to obtain a speech generating device. Maybe since we have a couple minutes talking like schools, the AEA is another route to getting a speech generating device that may be different than this funding through insurance process. Or like Krista mentioned before, if a family chooses to purchase an app for like a personal iPad, but again, hopefully they would be working with a speech language pathologist in both of those cases. I don't know if you want to add anything to that.
Well, one I would add, these methods are typically for those high-tech systems, usually low-tech systems or unaided systems. You don't really need the funding for those. And then one other resource that we have here in Iowa is through Telecommunications Iowa, and they have been assisting certain families with certain income levels with getting the iPad and the app, the communication app. But they do need an SLP's like referral or documentation that it is needed. So yeah, there are a variety of ways. Also, there are some charities and grant programs out there to get devices funded. So, but the prescription part, I wanted to make sure that I kind of covered that for this webinar. Okay, so I really wanted to spend some quality time here on some common myths about AAC. So the first one is probably the most common one that I hear, and that AAC will prevent a child from talking, or it will stop their speech and language development. And like I said, I hear this one a lot, but there is a lot of research to back up the fact that AAC will not keep someone from developing or using their oral speech. It actually tends to have a positive effect on speech production because it can decrease the pressure a child might be feeling. It can provide a consistent speech model, and it can strengthen the association between words and symbols. The next myth is that AAC would only be for someone who's completely nonverbal. So that is not true. AAC is beneficial for both nonverbal and partially verbal individuals. Many people use AAC part-time to repair communication breakdowns, to clarify unclear speech, or to even initiate conversation. It can augment, like we talked about, augmentative. It can augment existing speech rather than replace it. So it could enhance a child's overall communication and their language development. And it may really help with communicating with unfamiliar listeners. So oftentimes family members may be able to understand their child, but unfamiliar people may not, or even people like at school or other children. So it's not just for basic needs. It could be expanding communication for novel ideas and telling stories and talking about topics of interest. So as I stated earlier, breathing is the only prerequisite to start AAC. There are really no other cognitive or sensory motor skills that are required. Not matching pictures, not pointing. Eligibility is it's just based on an individual's communication needs and not on skill checklist. Waiting to introduce AAC can cause increased frustration, with communication on the part of the individual as well as their communication partners. It could cause depression or withdrawal from social situations. And if you wait a really long time, you can build up resistance to AAC when it is finally presented or introduced. I also touched on this, that low tech does not have to come before high tech. There's no research to support this required progression from low tech to high tech. It's really just about a child's needs, and oftentimes both low tech and high tech tools are used simultaneously. Sometimes high tech can be more motivating than low tech because it has speech output, and sometimes it's also easier to make changes on the fly to a high tech system. AAC is not just one single thing. It's not necessarily like a single device. We all use multiple modalities to communicate, and so AAC usually can and does include oral speech, manual signs or gestures, communication boards, and high-tech devices. You want to have a backup for those high-tech systems because they often fail. They're not charged, or they're having some sort of glitch, so it's great to have a backup. Sometimes people even switch between two different communication apps. And AAC is not always just the device, it can be the materials that come with it, like a stylus or a switch or a wheelchair mount. So it's kind of a combination of technologies. And then the last thing I wanted to touch on is the fact that AAC is not a last resort. It should not be delayed until every other intervention has failed. Early AAC introduction prevents communication failures, and it supports faster development of communication skills. So I have many children who come for my services and then they graduate. I say, they don't need their AAC system anymore, or they start to use it less and less as their oral speech develops. Research does show that waiting can hinder effective communication, and for some kids, it's just a transitional step in their communication journey. So that about sums up my myths, and these are some of the references that Jenny and I used for our presentation today. And now we'd like to open up the Q&A for questions.
I was really quick just going to highlight one reference, Krista, if you'd go back.
Sure.
The milestones I was referencing from the American Speech Language Hearing Association is that third reference in the list that links directly to their milestones, and they share milestones from birth to I think maybe middle childhood. I can't quite recall off the top of my head. But if you're looking for something that's a little bit more comprehensive, that is a nice resource to use.
Wonderful, thank you. So we will open it up to questions. Please type your question in the Q&A section of the webinar toolbar, and we will cover as many questions as time allows. And I wanted to kind of a follow-up to the references you are mentioning. Are there some educational resources you would recommend for families to learn more about AAC?
Well, the American Speech Language Hearing Association has some good references as well. There's also, I'm part of an organization called the United States Society for AAC, or USAC, and they have resources for families on their website. So I think those would be a couple of good places to start, but also for families just to talk to their school SLP or the SLP that they've been referred to, just because sometimes some of those resources might be confusing or use jargon or terminology that they might not be familiar with, and their SLP can help kind of decipher that with them.
Yeah, and I do think those resources are a great kind of first step and stepping stone to just learning about like what is this, but then deferring to the treating clinician is always something I recommend because they know that individual very well, and there is a lot of kind of tailoring to the individual required, as Krista was talking about, for assessing most beneficial components of AAC. So it is really important to get that input from the direct like expert who knows that individual the best as well, so they can kind of map onto that person specifically.
Okay, thank you. We have a question that's kind of a follow-up to the insurance coverage question. Does Medicaid generally cover certain devices over others? Or any tips on working with insurance for families to get coverage for AAC?
No, it's not necessarily that they would cover one device over another. The SLP has to do a very thorough and detailed job in explaining the choice that they've made and why it is the best choice for that person. And they also have to rule out all the other options. So that has to be clearly outlined in the evaluation. Our evaluations tend to be 10 to 15 pages long. So they're very exhaustive reports, and we've looked at all these other methods. So that's what insurance is going to be looking for, whether it's Medicaid or Blue Cross Blue Shield or any other kind of insurance. They're going to be looking for specific data and even phrasing that indicates why this is the best system.
And I'll say from that insurance standpoint, it is a matter really of the SLP understanding like how do you document that effectively and what are sort of the unstated rules that insurance wants to like in terms of the information that insurance wants to see. But it will cover any program as long as you have shown this is medically necessary and it does support communication more than other options, and that certain other options are not viable in meeting this person's communication needs from a medical necessity standpoint.
Right. They're not interested in like academics as much, even though we all value that. They're looking at the medical needs and how they're able to communicate, pain and some of those basic functions. I was going to say one other thing about insurance. Oh, if you're working SLPs who may be a little less experienced, the funding departments once they've just determined which system is best, they can work with the funding department from that company, and they can help them to navigate some of those pitfalls with insurance.
Thank you. Krista, you mentioned one of the myths is, that AAC will prevent the child from talking, or one of the myths is that it would prevent a child from talking. How often do you get parents who will not allow their children to use any devices despite the child needing it?
Well, I may not be seeing them because I do specialize in AAC, and so, but I do work with families who are hesitant or they have a lot of questions. And so there is counseling involved in just kind of figuring out, like hearing what their concerns are and trying to meet them where they're at. So again, it's a common concern. But typically if they're with me, they're at least a little bit open to the idea of trying it. And then, if the family wants research, I can provide them with that. If the family wants other families to connect with, I can provide them with that. If they want to know more about, my experience with other children, I can provide them with that. You really have to tailor it to what resonates with the family.
And I'll say, because I'm usually seeing people earlier on, like it's not uncommon that I might see people and then say like, okay, you should see Krista now for this very specific AAC referral, or you should go back to your treating clinician and ask about this. So I do see lots of families who are very hesitant or who say like, for whatever reason, sometimes culturally, sometimes for another reason, they just are not ready for that. I try to talk to families a lot about, that augmentative piece, right? Like this is a good support to help your child communicate right now. And I try to approach it in that sense. Like the hope is that we're helping communication right now, and we're still always going to be supporting verbal communication if that is the goal. But let's think about ways to get your child's needs met because they don't have another strategy yet. And so kind of talking about it as that augmentative piece versus the alternative piece in the moment can sometimes be helpful. And other times it is a continual conversation over time. And again, that's why it's so important just to refer to speech therapy in the first place, because I've had families I've worked with where it is a year-long conversation, and it takes that long to get to a point to agree to trying something. But in the meantime, we're still providing speech therapy services that are beneficial in other ways to the child's communication skills. So it's not an all or nothing where it's like, you have to get this AAC device or else.
Right.
It should be a continual conversation and consideration where you're partnering with the family to think about how it fits in best with their needs and priorities.
Thank you. What can caregivers or clinicians do to support successful AAC use?
That's a big question. I think that, well, what I always say is I don't want to overwhelm caregivers. Like, you have to use it all the time, 24/7. It needs to be, I usually start small. Let's integrate the system into, one routine of your daily life. But again, it doesn't have to be extra. Like it could be integrated into things that they're already doing with their child. So we start small and we get some success and we build from there. So, but that's kind of the first step, not just leaving it on the shelf or leaving it in the backpack, but actually trying to integrate it a little bit into daily life. So I think that's the one thing that I usually start with caregivers, and then we build on that. I think other professionals can also be checking in. Like I used to work in the schools, and so OTs and PTs knowing that a child had an AAC system, making sure that they brought it with them to their services, or teachers recognizing they should have it out in the classroom. So just, other professionals checking in on whether that device is available to the child at different points throughout their day.
Thank you.
Mm-hmm.
We talked a little bit about this, but are there options for parents through their phone, available on their phones, free options available, or more affordable options available via mobile devices, such as
Yeah, so
apps?
there are a lot of communication apps, but they are not necessarily created equal.
Mm-hmm.
So an SLP, again, is really the right person to help sort through that and kind of determine what would be a good match. But there are some more affordable apps and even some free apps that are quite robust. But I think it's good to do that together with a professional to kind of figure out the right system, and then how to kind of implement that or integrate it for the child. So they're not all created the same, and it's not a one size fits all, like maybe that works for one of their classmates or their neighbor, but it doesn't necessarily mean that it's going to work for them. But luckily, there are a lot of options, and they're getting more affordable too.
And I'll just say from an advocacy standpoint, because that is one of my roles is like advocacy for reimbursement. Um, we don't ever want it to be cost prohibitive, and usually insurance will cover that. Or the school, if they deem it necessary, has to cover that. So we don't want families to pay if they don't need to. We can, there certainly are different circumstances where it's like a patient just wants this right now, and or they don't want to go through the process, or I don't know, they just want to purchase something, then they can, but they should never have to, and that doesn't have to be an option.
Yeah, I mean, I don't want to toot my own horn, but I have a very long track record of making sure that families are not on the hook for a large bill for AAC. It's something that I pride myself on, and that I teach our graduate students here, that we just appeal and appeal. If things get denied, we appeal it. We find other funding sources. Yeah, we never want that to be a barrier to having access to communication.
We had a question. Thinking of using these devices by students in schools, do you have suggestions for orienting, teaching, supporting the learning curve for teachers, fellow students in communicating with the student, especially for younger students who are in the position of having to teach everyone else?
Yeah, that's a great question. Luckily, like I said, I worked for 11 years in the schools in Illinois before I came to Iowa, and so part of my job there was doing that education. So when I was using AAC with students, I was also educating all the people that work with them. So I provided in services, like general, like big in service to many people, as well as like smaller group meetings or team meetings, like monthly team meetings. So just, and then kind of in the moment, on the spot training as well. I also did, which I loved, was presenting to a classroom, like a kindergarten classroom, which had a child who was using AAC, and I could project their system up on the screen, and we could talk about it and talk about that it was their voice, and only they should be touching it, and some of the rules, but also how it worked and what they could do to be a good friend and partner for the child who was using it. So, and if you're an outpatient SLP, you can collaborate with the school SLP to help make sure that that education and training is taking place. You can also give resources for webinars or camps or family different trainings that's available. Some of the companies have free trainings too. So there's just a lot of ways to get that education. But those are some of the things that I did when I worked in the schools, and they're relatively effective.
Okay, thank you. Well, it looks like we have covered all the questions.